Okay. Good afternoon, everyone. I hope everyone is well out there in the critical care world. On behalf of Critical Care Services Ontario, I'd like to welcome everyone back for our second webinar on our series of talks focusing on the respiratory management of COVID-19 patients. This is part of our Ontario Critical Care Clinical Practice Rounds. I trust all will appreciate that certainly ain't easy for this Ukrainian boy to keep saying, so I'm going to be calling it OC3PR for the most part. For those who don't know, OC3PR was created to help address concerns expressed by health professionals like yourself to promote learning and help better align Ontario's critical care teams in the care we all provide in terms of medical and management issues, but also in terms of staffing and how we organize our ICUs, particularly in these days of COVID-19. I trust all will appreciate that most of us are health professionals and we are still technologically challenged. So bear with us if there's some glitches today. Remember to try to keep yourself muted. If you don't be surprised if Mike Sullivan, the mutinator himself, will mute you and seek you out. So we don't want to have that happen. We ask that you send in your questions to the Q&A headings. We have two of them again today. They're staffed by Doctors Josée Thériault and Neill Adhikari, who will be fielding the questions. So please send them in at any time. I'll also remind you there's an opportunity to send your questions ahead of time. And that's really important, particularly for our next webinar, which will focus solely on questions and answers on the respiratory management of COVID-19 patients. So please send in your questions, ideas, suggestions, and tips to the email address info@ccso.ca. We again encourage you to follow CCSO on YouTube along with Twitter and visit CCSO's new website when it's up and running. We'll ask you to take the time at the end to fill out the evaluation survey, as it's going to help us improve these webinars to better meet the needs of people like yourself. The last thing to know is we are working on getting these webinars certified and accredited for CME credits. And so hopefully that will happen by 2021. In terms of ventilating COVID patients, I recall some of the questions that were spurred by Dr. Gattinoni's team, an expert many of us are aware of, who suggested that there was perhaps two phenotypes of COVID patients with different ventilation recommendations for each. This, along with the debate as to whether to intubate all patients early, created a lot of confusion and angst amongst our teams that were caring for these patients. So here it is, almost a year later. Yep, it's almost been a year. I'm excited to hear about an update on best practice for caring for mechanically ventilated COVID patients from today's speaker, Dr. Eddie Fan. Those who aren't aware, Dr. Fan is an associate professor of critical care at the University of Toronto. He's an intensivist within the University Health Network. He's a graduate of the University of Western Ontario and received his PhD in clinical investigations from Johns Hopkins. He's currently the medical director of the extracorporeal life support program at the Toronto General. His academic work focuses on advanced life support for acute respiratory failure, along with investigating patient outcomes from critical illness. His objectives today are to discuss the management of patients with COVID-19 in terms of ARDS using best available evidence, and to also report on the outcomes of mechanically ventilated patients with COVID-19. Dr. Fan, I want to again thank you for agreeing to do this, and I'll turn it over to you, Eddie, and we'll listen attentively.
Great, thanks very much, Dave, and thanks for the invitation to speak. It's a pleasure to come and talk about the respiratory management of COVID-19 patients, and I hope, like many of these presentations, that the discussion and the questions will be sort of the meat of what we're going to talk about today. So we're going to talk about COVID-19 ARDS management. Here are my disclosures. I'm not going to speak about any specific devices, and they shouldn't be relevant for today's talk. Okay, so I think the key overriding message I want to send today with Dave's very nice introduction is the idea that you already know how best to manage these patients, these mechanically ventilated patients with ARDS because we've been doing it for the last 20, 30 years. And the premise of that is that, as Dave alluded to, is that ARDS is a syndrome. A syndrome is a man-made definition. We've had a definition for ARDS since this seminal sort of first paper, the inception of the term in 1967 by intensivists in Colorado, describing this hypoxemic respiratory failure syndrome caused by a whole host of etiologies, which leads to the heterogeneity. And interestingly, even nearly 50 years ago now, or more than 50 years ago now, sorry, the therapies they discussed in this case series are the same ones we're talking about today and the same ones we're going to talk about today. Positive pressure ventilation, PEEP, steroids, I think you might come, not so much specifically for these patients, but clearly the recovery trials showing us that dexamethasone being useful in these patients who are admitted to hospital with COVID-19. But heterogeneity is a part of the syndrome. So the fact that you have various causes, various presentations that fall under the umbrella of these clinical features and characteristics, that's something that's been long known, okay? And again, so now that we've had, at the outset of the pandemic, sort of the first reports to the WHO on New Year's Eve in 2019 of this novel coronavirus in China, leading, as you can see on the right, to very severe bilateral pulmonary infiltrates and a syndrome of hypoxemic respiratory failure in some patients with very severe COVID-related pneumonia, is just, I would put to you, a new cause of ARDS, just like other viral pneumonias, influenza, seasonal influenza being an important cause. These things lead to ARDS. And so the answer to my question is yes, COVID-19 leads to ARDS. And as you've already heard from Dave, there's been a lot of controversy in the literature about this. Many of them from investigations, editorials, viewpoints from Dr. Gattinoni, who is a giant in our field, has made important contributions to critical care medicine, not the least of which is around ARDS and mechanical ventilation. But I would say that, again, like many things, when COVID-19 came on the scene, there were a lot of anecdotes. There was a lot of science by press release, science by Twitter, science by social media. And what we needed and what we have now is an increasing amount of data to help better guide decision-making around what COVID-19 pneumonia is. Does COVID-19 pneumonia lead to ARDS? And therefore, how best to mechanically ventilate these patients? And just as an example, I put maybe one of the more recent outputs of a very large cohort of COVID-19 patients who were ventilated in Spain, sending a message that essentially these patients are very much like other ARDS patients, and therefore, to get to the punchline, we should ventilate them like other ARDS patients. So here's part of this controversy. This is one of the earlier reports from Dr. Gattinoni and his group, and Luigi Camparota from Guy's and St. Thomas's in the UK, demonstrating this idea on the right, on the left, that there seem to be these two phenotypes, and this is the term that they used. One where you'd see similar degrees of hypoxemia. So this would, at least by the Berlin definition, qualify for severe ARDS, but very different radiologic appearances. One sort of relatively spared in this slice, of the CT scan, versus those who have much denser consolidation on their CT, and that being associated with differences in lung compliance. You might imagine that the CT scan of the patient on the bottom here in red has very poor and very impaired lung compliance as compared to the one at the top in blue. And so what they described was this idea of two phenotypes, the L and H phenotypes. And it's kind of a nice sort of system because the phenotype L stands for low elastance, low VQ mismatch, low recruitability, and low PEEP response. There's really not a lot of recruitability in this lung because most of it is already open. And then they described the H phenotype being, again, representing high, and this is a mistake here in Luigi's slide, should be high lung elastance, representing low lung compliance, higher recruitability because there's more consolidated regions, high degrees of shunt and dead space, and as a result, again, of this consolidative pattern, a higher PEEP response. So the interesting thing I would say, again, is that at the beginning, these were hypotheses based on physiologic rationale, which was relatively good. and limited number of patients. These early reports from Dr. Gattinoni were based on reports of 16 or so patients from Italian ICUs who unfortunately encountered the pandemic much earlier than we did here in North America. And we needed more data to validate this situation. The second thing I would tell you is that they also mentioned the fact that many of these patients transition from the L phenotype to the H phenotype. And you can see here in Luigi's slide, he has this time and treatment. So depending on how much time elapses and what kind of treatments are or aren't provided, many of the patients start off with the L phenotype and progress to the H phenotype. And to me, that's interesting because really these just probably represent phases of ARDS. If we have a patient with community-acquired pneumonia on the ward, they may start off with something looking like the L phenotype. There's not that much consolidation. The lung compliance or respiratory system compliance is relatively preserved, and there's not a lot of shunt at this point. But those that worsen and progress will eventually may develop ARDS, and then they progress to the H phenotype. So to me, this is less an issue of phenotypes than it is the timing at which we look at the patients and the evolution of their disease process. And again, you might imagine this as a progression of community-acquired pneumonia, of influenza, aspiration pneumonia. I think many things could lead to this kind of transition. And I think this is an important thing to think about because again, we actually have very elegant data in the ARDS world about how we determine true subphenotypes or phenotypes in ARDS. And these are work you might be aware from Carolyn Calfee and colleagues at UCSF, who's really been a leader at helping to develop methods to determine phenotypes. And here's just one example of her work published in Lancet Respiratory Medicine, where they define this hyperinflammatory versus hypoinflammatory phenotype. And the important thing about these phenotypes is that they have different treatment responses. So when they measure along the x-axis here, various demographic variables like age and BMI, things that we do on the ventilator, plateau pressure, respiratory rate, PEEP, inflammatory markers like PI1, tumor necrosis factor alpha, et cetera. You through a method called latent class analysis, they define two different groups. And interestingly, when they look at previous randomized control trial data, you see that these two groups or these two phenotypes respond differently to interventions such as PEEP. So when they look back to the alveoli trial, the hyperinflammatory phenotypes seem to have a beneficial response to PEEP, whereas those that were hypoinflammatory, higher PEEP was detrimental. So again, not to criticize too much Dr. Gattinoni's initial conjectures, but again, that was I would say an initial observation at the beginning of the pandemic, and as the pandemic evolved and more data became apparent, we could see that more sophisticated methods may not demonstrate the presence of true phenotypes. And another important part of Dr. Calfee's work is that when you identify these subphenotypes, they're quite stable over time. So if you're hyperinflammatory, you're sort of in this group for up to a week. Whereas again, I might say that in the H and L phenotypes, so to speak, they probably more represent phases of the disease process depending on where you catch your patients. And again, here's just a summary that we published in Lancet Respiratory Medicine, looking at the time, the published data that started to emerge from different jurisdictions around the world. And what you could see here, if you're focusing on things that might sort of help understand the severity of the underlying lung injury, like PF ratio and compliance, some ventilatory variables like plateau pressure, PEEP, and tidal volume used, they're actually very similar to those in ARDS populations without COVID-19. So you could see the PF ratios in the range of these various COVID-19 cohorts with that in a very large global study of LungSafe. The plateau pressure was also quite similar. Interestingly, there were higher amounts of PEEP given to these patients in the COVID-19 cohort, and tidal volume was also pretty much the same. So as data actually emerged about the ventilatory variables and the respiratory mechanics of these patients in much larger numbers, and you could see here these two cohorts from New York representing nearly 500 patients, it seemed that on the whole, physiologically and from a respiratory mechanics point of view, they look like regular ARDS patients. And indeed, just summarized more pictorially, which is nice for respiratory system compliance, what you could see here is that, again, that the vast majority of these COVID-19 studies are similar. These are the data with error bars from LungSafe, so very similar degree of respiratory system compliance in the vast majority of COVID-19 studies. And again, not surprising that some might have higher compliance because there is going to be heterogeneity in ARDS, because heterogeneity is the name of the game here. That's something that we've known about since the inception of ARDS in 1967. And then some other things that are just, again, slowly helping us to refine all these initial ideas that we had and which again seems very reasonable because at the beginning of the pandemic, COVID-19 was something new. We didn't have a lot of data. We'd not seen it before. So lots of conjectures. I think another thing that was sort of popular at the beginning was the idea that there was a vast inflammatory cytokine storm in the setting of COVID-19. This very nice meta-analysis published in The Lancet recently by Daniel Leisman and Cliff Deutschman in the United States, really showing that when you look at severe COVID-19, this is just using interleukin-6 as an example, but they looked at other biomarkers. Actually, the levels are at quite a bit lower than patients who have hypo or hyperinflammatory ARDS or sepsis or other critically ill conditions. So this idea that COVID-19 is special also because there's cytokine storm, this sort of data seems to debunk that. And again, when you look at the increasing number of autopsy studies that are being published about COVID-19, again, it seems that in the vast majority of these histopathologic findings, what you see is ARDS, diffuse alveolar damage with hemorrhage, which is a part of DAD, with some microthrombi, which is a part of DAD. So even at autopsy, these patients look like they've had the pathophysiology associated with ARDS, which is diffuse alveolar damage. Now, that's not to say there aren't some other additional findings which are relatively novel and perhaps unique. And again, this whole story around probably a disturbance in angiogenesis, coagulopathy, perhaps some kind of endotheliopathy, which is leading to more and more thrombotic complications. This seems to be something that's seen at autopsy. And again, a lot of controversy at the moment as to whether how best to treat these complications when they arise. Should patients with COVID-19 and critical illness be treated with therapeutic levels of anticoagulation given this higher risk of thrombotic complications? Again, I would say at this point we have equipoise, and the good news is that there's data coming from the ATTACK trial in partnership with the Active-4 group in the United States and the international REMAP CAP study. So at the present time, it's an important question that needs to be answered, but we don't know what the right answer is yet. So I hope that whole preamble was to say to you that the data now suggests that patients with hypoxemic respiratory failure from COVID-19 pneumonia have essentially ARDS. Then we should use all the evidence-based strategies that we have to best manage these patients. And that would be the right starting point for the respiratory management of patients who require mechanical ventilation in your ICU with from severe COVID-19 pneumonia. And it's just to show that we codified some of these evidence-based interventions in a multi-society guideline a few years ago. This is maybe summarized in this nice graphic on the right, sort of suggesting, again, a sort of iterative approach to the management of these patients. And really what we're talking about are things that I'm sure this audience is well versed in, which is the use of low tidal volume ventilation, targeting 6 mils per kilo predicted body weight, higher levels of PEEP in those with moderate to severe ARDS, prone positioning in those with moderate to severe ARDS in the absence of contraindications, which really is an unstable spine. And in those who fail those conventional measures, a referral to a center that's capable of performing veno-venous extracorporeal membrane oxygenation or ECMO. These guidelines have basically been now absorbed into many COVID-specific guidelines, including the WHO guideline, the Surviving Sepsis Campaign guidelines, which again sort of states very much the same sorts of things. Oops, just trying to X out some of these waiting room things here. Considering higher PEEP, deep sedation and neuromuscular blockade to facilitate ventilation targets in patients who have asynchrony, prone ventilation in those without contraindications. And then in those who fail those sorts of things, you could consider, we'll speak a little bit about the use of inhaled prostaglandins or vasodilators like nitric oxide, and also to consider a referral to a center such as ours that can perform veno-venous ECMO. And then again, some of these have been nicely summarized. This is a very short article for those who are short on time by Shrin Murthy from BC and Rob Fowler from here in Toronto. Again, stating that, again, do what we know works. Low tidal volume ventilation, low tidal volume ventilation, low tidal volume ventilation. That works. Prone positioning in those in the absence of contraindications, perhaps a trial of higher PEEP, perhaps a trial of inhaled vasodilators, and then again, consider early referral to a center capable of ECMO. So a few interesting observations specifically looking at some of these interventions in COVID patients. And again, this data seems to be building nicely. So you might be aware, and Neill Adhikari, who's helping with the Q&A of one of these sessions, is really an expert at the data around the use of inhaled vasodilators such as nitric oxide in patients with ARDS. And really a few meta-analyses by Neill has shown that unfortunately for all comers, the routine use of inhaled nitric oxide is well associated with a benefit in oxygenation, doesn't lead to a mortality benefit, and there really is no good threshold even at severely low levels of PF ratio. There really is no signal or threshold at which nitric oxide might be beneficial. There's also an increased risk of renal dysfunction in these patients. And similarly in COVID-19, here's a small study from Italy that again showed improvements, perhaps some improvements in patients with the use of inhaled nitric oxide. Really not a huge actually benefit, nothing significant in these patients, but oops, sorry, I forgot if I had, but interesting that they mentioned it, at least in the results, not so much here summarized in the table, that they did manage to prevent some of these patients from moving on to other strategies such as ECMO with the use of inhaled nitric oxide. I might mention anecdotally in our ICU, we did have quite a few patients in the first wave who were referred to us for potential ECMO that we did try on inhaled nitric oxide that had sometimes a very dramatic response. And particularly in some patients who unfortunately weren't, for a variety of reasons, candidates for ECMO, that also actually turned around on inhaled nitric oxide therapy. This group in Italy, basically with these small amount of data, suggested that there's equipoise around the use specifically of inhaled nitric oxide in patients with COVID-19, and I think are undertaking a clinical trial for its use in COVID-19 patients. Another thing that sort of came early was this idea of using higher PEEP in COVID-19 patients, and that perhaps some of them had increased recruitability, especially when they became more severe in the degree of lung injury. And this is just a nice paper, again, to say that like many things in the ICU, it would be good if we had some way to know who might benefit from our interventions, because obviously there are detriments, especially hemodynamic compromise from using higher levels of PEEP indiscriminately. And this is just a nice paper from our colleagues at St. Michael's Hospital using a single breath maneuver to calculate this recruitment to inflation ratio. And I might just say that for those that are interested, if you go to their Center of Mechanical Ventilation Excellence at St. Michael's Hospital, there's a nice video on how you can do this single breath maneuver on almost any ventilator. So it's very quick and easy to do. And basically when you calculate this ratio, if it's over 0.5, it suggests these patients have higher recruitability, and these are the patients that might respond to higher PEEP. And that's what they saw in this very small case series from COVID-19 patients in China, working in collaboration with investigators in China. And in fact, there seemed to be a synergistic effect in the use of higher PEEP and prone positioning for lung recruitment in those who had high recruitability. So just again, another simple bedside test that might help guide for clinicians which patients might be good responders to higher PEEP and prone position, and maybe those who you might want to avoid that and maybe try other strategies or make an earlier call to a referral center for potential ECMO. Here, just again, some data suggesting the potentially synergistic effect of both higher PEEP and prone positioning in patients with COVID-19. This is from a German group, although Art Slutsky is one of the co-authors. And again, it just shows a very nice oxygenation response, a decrease in the radiographic opacities after higher PEEP, and that seemed to be synergistic in those who had both higher PEEP and prone positioning, especially over the first 3 courses of prone positioning. So again, suggesting that at least in this group, they seem to be high responders, highly recruitable, and it seems that higher PEEP is definitely an intervention that's worth a go in these patients with COVID-19. And then finally, lots of controversy, as you might be aware recently, around the routine use of neuromuscular blocking agents. Original data out of France from Laurent Papazian suggesting this was a good idea for moderate to severe ARDS patients for 48 hours with infusion of cisatracurium. The Rose trial suggesting there was really no difference in outcomes and maybe slightly worse long-term outcomes in those who were paralyzed with cisatracurium. Here again is a look from France, suggesting that there really wasn't much of a difference. Again, they were using this kind of a pilot data to suggest there's equipoise around the use of neuromuscular blockade specifically in COVID-19 patients, and again, using it as a rationale to engage in a clinical trial about this indication. But I would say that in many of our patients, I'm sure in your ICUs as well as in ours, as they progressed in the severity of both their hypoxemia as well as difficulty in ventilation, as the COVID-19 progressed in certain patients, certainly deep sedation and neuromuscular blockade, we used it quite frequently to manage these patients, to manage both refractory hypoxemia and refractory hypercapnia. Just briefly to give you some ideas of the results we've had for ECMO for COVID-19, we've received quite a few referrals from, I'm sure, people who are on the call and centers all around the province, both during the first wave and in the current wave. And part of that was the changing, again, understanding around the utility of ECMO for these kinds of patients. Here's an early pooled analysis from 4 case series out of China showing survival of nearly 0% in almost all of these series. So this sort of led to early calls for a moratorium on ECMO use in these patients because it seemed to lead to very dismal outcomes. And again, this is, I don't think, any fault of the clinicians or the investigators who reported these findings, but really, again, a lot of unknowns at the start of the pandemic, maybe intervening with ECMO as an ultimate salvage therapy when patients unfortunately were already too far gone, leading to these poor results. And as the pandemic went on, I think using, again, our evidence-based strategies, and again, we stuck to our usual inclusion criteria for COVID-related ARDS, which would be the EOLIA inclusion criteria to choose patients to put on. In the first wave in the spring, we ended up putting on 36 COVID patients. We now are up to about 52 patients that we've put on ECMO. Again, one of the strategies that was quite different than previous, some of my colleagues on the call would know, is that we tried, again, to avoid going out to cannulate these patients remotely. We tried to move patients early to our ICU to watch, and if they needed ECMO. So that was a reduction in the amount of remote cannulations. Typically, we cannulate about 35%, 40% of patients in an average year remotely, because patients are unstable and they get cannulated at their referring center. The average age was 51. Most of them were male. This also is consistent with international experience. All these patients were supported with VV ECMO in the first wave, and all of them had 2 cannula configuration, except for one patient where we actually couldn't put the drainage cannula in femorally due to vascular issues. So the patient actually had a single dual lumen cannula put in the IJ. These patients had relatively long duration of ECMO run, which again is also quite consistent with the international data. And we were quite busy at the height of the first wave. We actually had 14 COVID ECMO patients on simultaneously. We actually currently have about 12 COVID patients on ECMO at the moment. So the initial outcomes were 64% survived to decannulation. So about a third died while on ECMO. They were on for about 2 weeks on average, and slightly less survived to hospital discharge. These patients actually had quite a few complications, and most striking for us was this nearly 4-fold expansion in intracranial hemorrhage, again, perhaps related to the underlying issues that COVID has with the coagulation system. Typically, we have a 5% intracranial hemorrhage rate, which is similar to the international experience in patients supported with VV ECMO for respiratory failure. This was nearly 4-fold increase in that rate, and we're still investigating the reasons for that. We actually didn't see as many circuit thromboses and need for circuit changes as many other centers did, although this number here is still a bit higher than our usual situation in non-COVID patients. And again, this is just to show you now we have better data suggesting that our results are in line with our international partners. These are data from Paris, where they have a very large, if not the largest ECMO center in Europe, from La Pitié. And what they showed, they reported on 83 patients that they put on VV ECMO in their first wave for COVID-19. And again, what you could see here is that at day 90, again, about a third of patients had died, sort of reflecting a very similar outcome to the international experience for ARDS patients supported with VV ECMO who don't have COVID. And we also reported data from the Extracorporeal Life Support Organization, which is the largest. This is over 1,000 patients who were supported with VV ECMO, with ECMO for COVID-19. And again, what you see here is the cumulative, probably the more germane graph here is on the right, showing that the cumulative mortality again was around 36-37%, in line with the experience in other jurisdictions for the management of these patients. So to suggest that it is a viable option for the right patients, and again, maybe sticking to the evidence-based indications for the use of VV ECMO in these patients is the way to go. So just to conclude, critically ill patients with COVID-19, they develop ARDS. We know that ARDS is heterogeneous, and COVID-19 is a new cause of ARDS. I hope I've shown you that there's increasing data that suggests that it resembles typical ARDS in the vast majority of cases. Therefore, we should provide evidence-based management of ARDS, so early recognition is important, the use of lung protective ventilation, higher PEEP and prone positioning, consider perhaps the use or detection for bedside recruitability with the R to I ratio. And we would like to be called if possible, and in fact would be happy to get calls early about potential cases where the trajectory is worrisome or they're failing conventional measures to consider VV ECMO in these refractory cases within 7 to 10 days of the initiation of mechanical ventilation. And I think the other key thing is to be humble. Again, this is a new disease. It's a new look to the pandemic. And this line, when the facts change, I can change my mind, attributed to many famous people, perhaps last to Winston Churchill, is that, as we get more data, we might change the way that we think about the pandemic and its management. So I think we just need to be open to the idea of considering new data as the pandemic evolves. So with that, I'd like to finish. I'm happy to take any questions, and thank you again very much for the opportunity to speak today.
Oh, Eddie, that was fantastic. Nice and to the point. And, I really appreciate you addressing Dr. Gattinoni's issue. And with that, I think you raised a lot of questions about coagulation, which is going to be one of the future topics, because I think it's really part and parcel, perhaps one of the more unique aspects of COVID as compared to some of the other causes of ARDS. With that in mind, I thought we'd start with some of the Q&A. Josée, were you able to get some questions for Dr. Fan?
At this point in time, I don't have any questions coming my way, but I actually had a question. You've talked about the nitric oxide. Is there any evidence certain centers do not have nitric oxide, but may have access to inhaled prostacyclins? So any data or evidence that this could be helpful in the same way that nitric oxide has been helpful and maybe alleviating some ECMO or preventing some patients to progress to ECMO?
Yeah, I think it's a great question, Josée. I'm not aware specifically of any data of inhaled prostacyclins in COVID patients, although I'm sure if we looked, there probably are some reports. I think the mechanism is pretty similar. Perhaps some of the challenges around using something like inhaled Flolan rather than inhaled nitric oxide, maybe around the delivery, depending on the kind of delivery system that you use. There are now some, now commercially available delivery systems that might alleviate some of the issues that used to be more significant with sort of homemade solutions to aerosolizing things like Flolan and delivering it in the ventilator circuit. But again, I think maybe the message I want to send to everyone on the call is while these things, again, lessons from ARDS in general, is that while these things may improve oxygenation, which is really good, that we have multiple lines of evidence showing that oxygenation is maybe a poor surrogate for outcomes in patients with ARDS. So again, like nitric oxide is a great example where it proves oxygenation, but no randomized control trials really demonstrated that translated into a mortality benefit for patients. And while giving something like that in a center that has it available could buy time, that might also buy the time perhaps to make a call to a referral center, such as yours that could, or ours, that could provide ECMO in the event this neither works durably, which is part of what the data shows, or doesn't work at all. So I think, again, because we want to focus on interventions that we think are associated, again, with a mortality benefit. And unfortunately, oxygenation, while we're often very nervous about oxygenation for good reasons, improving just the oxygenation may not be enough for these patients.
Thank you very much.
Is there a stat that you target, Eddie, or like what guidance would you give some of the listeners, or in terms of oxygenation? What's good? What's adequate?
Yeah, I think, so again, I would use, the data until we have better data. And of course, there is a lot of ongoing controversy about what the right oxygenation targets are and whether we should be relatively conservative or liberal. And in fact, there is now a new extremely large international trial, Mega Rocks, underway to try to exclude a 1.5% difference in mortality from a conservative versus liberal oxygen strategy. But I would say at the present time, I would just take guidance again from the randomized control trials on ARDS. And then in the vast majority of the randomized control trials, the target oxygen saturation was 88 to 93%, for instance, in the ARMA trial, maybe perhaps slightly more, 88 to 95% in LOVES and OSCILLATE. So I would say that's a very reasonable target to use, and that's the target that we use in our ventilation protocols. For instance, we target an oxygen saturation of 88 to 95%, and that typically translates to a PaO2 if you're monitoring that of 55 to say 80, something in that range.
Okay, that's great. Neill, do you?
Yeah, thanks a lot, Eddie. That was great. I have a few questions here, and just to the questioners, if I don't get to your question, apologies, and we're going to keep track of this and put them together for the Q&A session in a couple of weeks. And you can, as Dave said, email additional questions to the email on the screen. Eddie, question about the perennial question of PEEP, and I guess a couple things. Practically, have you used the RI index, and how, as opposed to just sort of an empiric trial of, you know, higher PEEP for a period of time? And two, have you found what sort of rough range of higher PEEP in the patients that respond to it has it been in COVID-19? And do you think it's different from responders in regular ARDS, non-COVID ARDS?
So these are all good questions. And again, if Luciano Gannoni was listening, he'd be telling us, as he's been telling us for 40 years, that we still don't know how to set PEEP. Something that we're still talking about, and we'll talk about, I'm sure, for many years to come. But we've done all those things that you've said, Neil. So I apologize if that's not a very helpful answer. But like, I mean, depending on who's on, the resources available, we've done sort of empiric, as we would in normal times, say going up on the PEEP FiO2 ladder from the, you know, ARDS-NET or from the Loves trial. So trying higher PEEP in those patients who are requiring high levels of FiO2, sort of empirically, and monitoring for problems like desaturation, arrhythmias, or hemodynamic compromise. When available, and in enterprising, our RTs are trained to perform the R to I measurement, and most of our fellows are also well acquainted. So when someone is in the room, or the RTs are in the room, and they decided, oh, the patient's you know, FiO2 requirements are going up, or they're still hypoxemic, they might do the R to I measurement and help inform whether we think a trial of higher PEEP may be useful. And then in our center, at least, we also not infrequently place esophageal balloons, and that might be another way for us to guide PEEP therapy. So if the end expiratory transpulmonary pressure is quite negative, we might increase PEEP to avoid collapse at expiration in those patients who have an esophageal balloon in place. I would say that in those patients who are responders, or even in those who are very hypoxemic, we empirically try PEEP, we're using very high levels of PEEP. So like we would in many severe ARDS patients, so PEEP up to 20, 22 centimeters of water in those who are in high levels of FiO2 by the PEEP FiO2 ladder, or those, again, who we might have seem very recruitable by the R to I ratio, and we might try very high levels of PEEP in those patients in the high teens to low 20s. Yeah.
Thanks. A couple of questions around around ECMO. Have your referral criteria changed at all from before? Like when you're talking about referring early, can you give a sense of you know, when people are calling you for how the patient looks when they're calling you, as opposed to what might have happened a year or two ago? Yeah,
I think we've had it all over the place. I think we've had some centers who have referred quite a few patients have called early. It seemed to, from wave 1 to wave 2, they're calling it much earlier now. At least they initiate a conversation, even if we don't feel the patient is a candidate at the moment, or you know, they're calling to say, we're just starting the proning process, and just to make you aware that if the patient doesn't respond to proning as we hope or would like, you know, that would this patient be a candidate for ECMO? And I think those are the kinds of calls that we actually prefer. I think, you know, as busy as it sounds, we get quite a few calls for referrals, but I think earlier calls are better than late. And because I think in wave 1, as we were all learning, we were getting many later calls at the beginning. So, you know, they've been intubated for 7 to 10 days. They were proning, and initially they were responding, and then they stopped responding. And then they thought something was going on, maybe a new VAP or something. So they investigated, and then we were getting called around day 9, 10. And that's, I think, part of what we've learned in wave 1 is that putting patients on late in the course, we might just be seeing them on this slow decline, and we intercept them at this point where, although the ECMO improves the gas exchange and the oxygenation, the outcome might be already determined despite ECMO support. Again, remember that it is a support and not a therapy for anything that's underlying. So I think that might be the message for the group here, is that we prefer to get calls early. We're always happy to take, and maybe we don't sound happy on the phone, but we're always happy to take calls early and discuss difficult cases and see what the thinking is and to keep the lines of communication open. I might just articulate that our criteria are very much, again, like our pre-existing criteria, which are Eolia. So we're looking for patients who are age 65 or less, as per the clinical trials. They have reversible, so COVID pneumonia probably, a reversible cause of respiratory failure. They aren't already in florid multi-organ failure. They don't have a lot of pre-existing comorbidities or pre-morbid dysfunction. And I think our colleagues in Paris, for instance, made the point that they saw, again, sort of being zealous about maybe putting patients on early in wave one, that patients who were 60 to 65 who had comorbidities, they actually fared quite poorly. And then again, the data from ELSO also borne this out, that age per decile of age as it increases is a very important risk factor for mortality. And so, so we're considering patients up to age 65, but again, in those who are 60 to 65, we really want them to be healthy, free of comorbidity in those patients. And then within 7 to 10 days, the closer to 7 days, the better, of initiation of mechanical ventilation.
Thank you. Couple questions about medication use. What's your practice regarding sort of routine DVT prophylaxis? Like, I know there's some trials going on, but as far as sort of usual care for patients, not on ECMO, but ARDS patients with COVID, any differences from before?
So again, no differences before, because there's no compelling data at the moment to suggest that we need a change in management. So our patients are getting the routine in the absence of an indication for actual therapeutic anticoagulation. So we actually find a DVT, we find a PE or something like that, or they go into atrial fibrillation. We're using our standard anticoagulation for DVT prophylaxis at our hospitals, unfractionated heparin, sub-Q twice a day. So that's what we're giving. And we're obviously trying to encourage enrollment of patients who meet inclusion criteria into one of these trials for testing the hypothesis of whether therapeutic anticoagulation in COVID patients is beneficial. So we haven't changed our prophylactic anticoagulation strategy at all, pending the results of some of these large randomized controlled trials.
And for dexamethasone, are you sort of following the recovery dosing, which is 6 milligrams a day, or are using more? I'm not sure if more was used in the Velar trial. I can't actually remember now. But are you just doing what the recovery dosing was?
Yeah, so it's a good question. We're using the recovery dosing, so the 6 milligrams of dexamethasone daily. And again, many patients that get referred from outside centers, they've already started or are midway through their course. And again, if we're getting that 7 days, if they had symptoms or admitted to the hospital just on oxygen therapy, then many of them may have already completed their initial course of dexamethasone by the time they come for ECMO consideration, just as an example. But we're following the recovery trial protocol there. I will say that we have tried in certain patients that are having refractory ARDS from COVID. So they're having prolonged mechanical ventilation or prolonged course on ECMO, and they don't seem to be making recovery. We have tried using higher dose methylprednisolone, such as in trials like the Lazarus trial from ARDSNet, and akin to what you're talking about, like in the DEXA ARDS trial from Jesus Villar, to see in these refractory cases whether we can reverse things. And then so there we're using, I would say most of us have been trying the higher dosing from the ARDS network, which was the 2 milligrams per kilogram methylprednisolone daily in divided doses for up to 2 weeks.
All right, thank you. Josée, any questions directed your way?
No new questions. You've been going at it, Neill.
Maybe we have time. Maybe we have time for one more. I'm not sure, but there's a question here about APRV and whether you've been whether you think there's any benefit from it in COVID ARDS, and yeah, that's
I don't think there's any benefit for it at all. People have heard me speak about this before, maybe know that. And again, it's not so much that I don't like APRV as a mode. I think, again, for reasons that are not clear to me, there's not a lot of data supporting the use of APRV. I find depending on how you set it, so if you set it the way that they set it at the University of Maryland, like in the P high to P low with very short release times to manage to generate intrinsic PEEP and prevent lung collapse at P low. I don't know, I feel that that's a very injurious way to set mechanical ventilation. Typically the release volumes in those situations are in excess of the 6 to 8 mils per kilo we would consider protective. I think people who tell you that that's not a tidal volume, I also don't understand that, because to get the patient back to P high, you have to put that volume back in to pressurize the lung again. So that is a tidal volume. And I don't understand why you want to, again, like with the data that we have about moderate to high levels of PEEP, at least in severe patients, the potential benefits is that why you would want to manage intrinsic PEEP. So it's very difficult using short release times, say less than a second or less than 0.8 seconds, to generate intrinsic PEEP. You don't know how much you're really generating as compared to setting an extrinsic PEEP. And in fact, if you think about the time constants of the lung, if you think about that at all, or maybe when you're falling asleep, that the intrinsic PEEP that you're generating is probably in the most compliant areas of the lung, exactly where you don't want the PEEP, where you don't need the PEEP. Right. So to me, it's, and my favorite line about APRV is from RT from UCSF, Rich Calais, who once said that APRV is the devil's spawn. And I think it's just a matter of, we need data. Like, this mode of ventilation might be very good. And for proponents who think it's very good, there's a physiologic rationale and all this sort of thing. So we just need data. So before we adopt any new mode of mechanical ventilation, my bias would be to say, show me how it's better than what we already have.
All right, thank you.
Thanks, Eddie. I must admit, I got a little nervous when you talked about the devil's spawn. I didn't know where that was going next. And so I think what Maria's putting up there for everyone is a SurveyMonkey link. I think we would all appreciate if people took the 39 seconds to fill that out. It certainly would be helpful for us going forward. Eddie, I think that was excellent. We truly appreciate you taking the time to do this, recognizing that it is a lot of work putting it together. I hate to think how many studies that you looked at to try to make it simple for us, but we certainly appreciate it. I also am going to thank you in advance because you're coming back in 2 weeks, because Adhikari promised us that you would do that. And so you are on his Christmas list this year. I'm glad to say that, and it will be into 4 figures, the gift that he'll be bringing you. So that's good. So I would ask everyone, take the time to do the survey. I would also ask everyone to come up with some questions and send it to the info@ccso.ca. And Eddie promises to give such a good talk again on answering your questions, including, what truly is the devil's spawn. Is it APRV, or is it someone whose name will remain nameless on this? So with that, I want to thank you again. Neill or Josée, any final thoughts to pass on?
No, I don't think so. Thanks to some people have asked questions that we haven't addressed, and please join us again in a couple of weeks and we'll try to address them. And thanks again, Eddie. That was very, very clearly presented and very helpful and practical. Thank you very much.
Thank you very much, Eddie. And yes, there was a question forwarded, but we'll keep it and address in 2 weeks. Excellent. Thank you.
So I look forward to seeing everyone. It is December 22nd, which will be the next OC3 PR. And I'll never forgive Dr. Adhikari for naming it that. But I wish everyone the best. Eddie, thank you again. We'll see you December 22nd. And everyone have a good time. Stay safe. And we look forward to seeing you again. All the best. Take care.
Thanks very much.
Thank you. Have a great day.